Go. So we are live.
Hi friends, I am Dr. Pramod Zog from Pune, and we are going to discuss about a topic called allergic disorders in children with special reference to allergic rhinitis. And with me, we have Dr. Chetan Trivedi, consultant pediatrician from Ahmedabad, and Dr. Nishchal Bhatt, consultant pediatrician from Ahmedabad with special interest in adolescent pediatrics. And both of us are very good friends of mine, and I'm sure you'll get a lot of information about this particular topic. Why we have chosen this topic is because allergic rhinitis definitely continues to be a major problem. And in spite of the pandemic of COVID last year, allergic rhinitis and allergic disorders have not gone down because children were inside, parents were inside, and when they were outside, they were using the mask. So the infectious disease have gone down, but the allergic disorders have not gone down. And I always feel that now the days are for a daytime pediatrician who would be an expert in breastfeeding and nutrition and adolescent medicine and allergy and so on and so forth. So our friends must know a lot about allergic disorders. Second important reason is many of us keep treating asthmatic children and the asthma doesn't get controlled, and one doesn't understand why it is not getting controlled. And one fine morning, someone says 80% of asthmatics have allergic rhinitis as a comorbid. And then you realize that it is very important to treat allergic rhinitis as a comorbid in children with asthma. And lastly, there is a new molecule called Velastine, which is an antihistaminic, a non-irritating molecule, and we should know a bit about it because it's a new kid on the block. So with that, we will discuss about this particular topic. In the beginning, I plan to give you some information about allergic rhinitis. And as you can see, I am the professor of pediatrics at Dr. D.Y. Patil Medical College, and I am not allergic to anybody. Okay. So with that, we will start with the presentation of some cases. Initially, I will give you some comorbidities which are associated with allergic rhinitis. You can see she is Varshini. She is an 11-year-old girl with history of recurrent cold for the last 6 months and has paroxysmal sneezing. And the sneezing is more than 50 times in a few minutes. And that's an alarm for all the people in the house. In fact, one of my close relatives wakes me up in the morning with 50 sneezes in the morning. So every day I need not put any alarm. And that is very classical of allergic rhinitis. My teacher used to tell me that if a child gets up coughing, that is asthma. And if he starts sneezing and sneezing after getting up, that is allergic rhinitis. So one should be very clear about it. And this girl, the symptoms, they worsen in the months of August and September. It probably means that she has seasonal allergic rhinitis. Quite a few children have perennial allergic rhinitis. That is allergic rhinitis which is all around the year. And they are the ones who are allergic to the house dust mite or some cooking gas, fuels, and so many other things. We should also understand that another child, a 4-year-old girl, has cough, cold off and on, but almost persistent for the last 3 weeks. And in addition, this child has fever and headache for the last 4 days. And the cough is more in the lying down position. So obviously our listeners will understand that there is a bit of a difference wherein there is fever and headache, which probably means that the child has involvement of the sinuses. And as the cough is more in the lying down position, it goes more in favor of that. And this could very well be sinusitis. Another child who has history of cough and cold off and on for the last 3 months with history of fever and pain in the ear 2 months back, which subsided with the course of antibiotic. But the cold and the cough do not go away. So it probably means that the child had otitis media, which probably subsided, but the allergic element of this particular problem has not disappeared. And another case, a boy 3-year-old who has severe cough and cold and sneezing for the last 15 days, and it is recurrent since 4 months. The practitioner initially has given a course of antibiotic. And as everyone knows, pediatricians are giving nebulization like a welcome drink to any parent who simply utters C of cold or cough. And this child is not an exception. And cough syrups have also been received for 5 days, but there is no response. And someone has started on an inhaler for the last 5 days, and the patient has come to us for a second opinion. So it appears that this child is the one which probably I referred to in the beginning, a child who has asthma and probably having allergic rhinitis as a comorbid. And patients come to us with common symptoms of recurrent cough and cold with few additional points which are different in each patient. And these confusing symptoms should be dissected out and analyzed. Otherwise, every child has cough and cold. So we cannot diagnose every child as having allergic rhinitis because there are some comorbids. And that's why careful history and examination is a must. And we need to differentiate between allergic rhinitis and infectious rhinitis, allergic rhinitis with sinusitis, allergic rhinitis with adenoid hyperplasia, with otitis media, whether there is underlying infection, whether there is comorbidity of asthma, because the treatment plan will change accordingly, and my learned colleagues will elicit it more in their presentation. So when do we call it as allergic rhinitis? Is when the symptoms are suggestive of allergic rhinitis when two or more of these four symptoms are present for more than an hour on most of the days. So there is watery rhinorrhea, sneezing, which is particularly paroxysmal, nasal itching, and nasal obstruction, of which watery rhinorrhea and sneezing and nasal itching are extremely important components. And if two or more of these are present for more than an hour on most of the days, we should think of allergic rhinitis. And there are certain symptoms which are usually not associated with allergic rhinitis, particularly those where the symptoms are unilateral, or if there is a mucopurulent rhinorrhea, or if there is pain or recurrent epistaxis and anosmia. These are the children who need to be referred to an ENT surgeon. And whenever we come across a child with allergic rhinitis, we need to differentiate it from common cold. All of us know that whenever there is an infection, it will be in the family members, all the family members. Dr. Jog will be unwell, his wife, his children, parents, all will be unwell. That is common cold. It will not be the case in case of allergic rhinitis. And the last timing for common cold will be for a week along with fever. There will be constitutional symptoms like headache and body ache in common cold, and the nasal mucosa will be red. And children with common cold may not respond to antihistaminics or may respond in about 25 to 30% cases. While allergic rhinitis children, the cold will last longer, maybe for 10 days. The fever would be absent. There would be allergic signs, which I will tell you in a minute. Their nasal mucosa will be pale, and there would be a very good response to antihistaminics. Now, along with allergic rhinitis, many times we have ocular allergy symptoms like watering of the eye, itching, redness of the eye. And that's why this is allergic rhinitis with conjunctivitis. It becomes allergic rhinoconjunctivitis. Okay, some children have atopic dermatitis. Some of them have fullness of the ear, and quite a few have palatal pruritus. So they will always produce some sound as if there is some itching on the palate. And I already told you some symptoms of the comorbidities and the complications like sinusitis, where there will be headache, bad breath, that is called halitosis. I was told by my teacher long back that those who have sinusitis will give very bad breath to the people in front, while they themselves cannot smell that particular bad breath. Okay, and the cough will be in the lying down position. There will be obstructive sleep apnea in certain children who have adenoid enlargement, where there will be snoring, mouth breathing, and hypernasality of the voice. And some children with otitis media will have effusion, and some of them with asthma will have uncontrolled asthma. So the basis of allergic rhinitis is that it's a chronic inflammatory disease of the nose, which is induced by IgE antibodies after exposure to an allergen. So whenever the mucous membrane of the nose gets exposed to an allergen, for example, a pollen, then in the beginning, there is production of IgE antibodies. This is sensitization. And when this child again gets exposed to the pollens after a particular period, there will be production of IgE antibodies again. These IgE antibodies will be sitting on the mast cells. And whenever there is an allergen which cross-links these antibodies, the mast cells will degranulate and there will be release of histamine. And histamine is the main culprit behind all the allergic problems. This is extremely important. So remember that many patients, they say, sir, when he had this particular fish, when he went to the seashore, he never had this problem. But when he ate it again for the second time, he had the problem. This is because the first instance was of sensitization, and the second time it was the real allergic problem. And this is the natural history of allergic disease in children. You will find that in the first year of life, quite a few children have gastrointestinal problems like the cow's milk protein allergy, which usually subsides over years. Some children have atopic dermatitis in the first year, which also subsides slowly. Some of them in the preschool age, they start showing wheezing in the form of, say, asthma later on. And some of them have allergic rhinitis, which starts little later. And this is an important atopic march. This is a natural history of allergic disease in children. So you should always ask for a runny nose, paroxysmal sneezing, nasal itching, nasal block, watering of the eye, itching of the eye, redness of the eye, atopic eczemas, asthma-like symptoms, and family history of allergy. And you can see that there are some signs, particularly itching of the nose, allergic shiners, those who have darkness under the eye because of the venous blockage, a transverse crease at the junction of the cartilage and the nasal bone, and an allergic salute. Every one of us has a different way of pacifying the nose, and the facial grimaces are different. So this is an allergic salute. And the symptoms of allergic rhinitis have been grouped into sneezers and blockers. Those who are sneezers usually have this particular problem of sneezing and anterior rhinorrhea and itching and conjunctivitis, which is worse during the day and improves at night. While the blockers have little sneezing, but they have a thick mucus and severe congestion, and they are worse at night. And the classification, which is by the name of as allergic rhinitis and its impact on asthma, where you should remember that the figure 4 is important. The allergic rhinitis could be either intermittent or persistent. So if at all a child has a problem which is less than 4 days in a week or less than 4 weeks in a year, then it's an intermittent allergic rhinitis. While those who have a persistent problem have a problem which goes on for more than 4 days in a week or more than 4 weeks in a year. Either of these could be mild or moderate to severe. If it's a mild problem, the sleep is undisturbed. The child is fine, activities are not affected. Next day he goes very well to the school. But if it's a moderate or a severe problem, the sleep is disturbed and the child is really not willing to go to the school next day and the activities are affected. We will discuss the management of allergic rhinitis in one of the talks. I will just tell you that drugs and avoidance of allergens and immunotherapy are some of the important components of management of allergic rhinitis. I will not elaborate it further, and the stepwise management will be discussed by Dr. Chetan in his talk, and we will just see some aspects of management of allergic rhinitis with asthma, because 30% of allergic rhinitis patients have asthma, 80% of asthmatics have allergic rhinitis. This one must remember. And allergic rhinitis is an important risk factor for asthma, and both of them, they share common allergens. That's why these days we call it as a unified airway disease, because the same allergens, whether they are pollens or house dust mites, they are responsible for allergic rhinitis or asthma. And I told you that proper treatment of allergic rhinitis improves the asthma control and the pulmonary function test. And the second comorbid, which is important, is allergic sinusitis, because the right term to be used is allergic rhinosinusitis, where there are combination of symptoms like nasal blockage, nasal discharge, which is anterior plus posterior. There is halitosis, that is bad breath, and loss of smell. There is also facial pain, headache, and ear pain. And in case of allergic sinusitis, the X-rays are not specific. The mucosal thickening in allergic sinusitis could be either allergic or viral or bacterial, one doesn't know. And the CT of the sinuses gives greater details, but does not guide about the etiology. And CT sinuses is expensive. The treatment of allergic sinusitis is same as allergic rhinitis, but the bacterial complications should be watched for. And in case if the discharge is thick, mucopurulent with postnasal drip, persistent for more than 10 to 14 days with fever, headache, and facial pain, and cough in the lying down position, they need to be treated for 10 to 14 days. Many times we get children with cold going on. They keep receiving medications, but no one treats the underlying infection. Okay. And that's why you should be very, very aware of this condition. Some children who have severe deviated nasal septum or a glued ear, or refractory sinusitis with adenoid enlargement, or obstructive sleep apnea with adenoid enlargement, or nasal polyps which are not responding to inhaled nasal steroids, then we need to refer these children to ENT surgeons. And that's why, my dear friend, just remember that you have to look for the cardinal symptoms, watch for comorbids, rule out and treat infections, and remember that treatment of allergic rhinitis improves the control of asthma. A few points about urticaria. Remember, urticaria, again, the basis is histamine, and the hallmark of urticaria is transience. The child will come to you with rash, which is probably following some physical factor. Like some children have cold water urticaria. They just go inside the bathroom, come out, and they have a severe rash. Some of them, they get drenched in the rain and they get this particular rash. So these are physical factors. Some of them, when they scratch the skin also, there is what is called a dermographism. So they get this problem. These are physical factors. There are some factors in the food. As we all know that there are children who are sensitive to milk or egg or soya or peanuts or shellfish and so many others. Some of these allergies are not common in our country, but there are different countries which present with problems related to different food items, and individual country differences are there. However, the basis is again histamine, and food allergy also has to be remembered. And there are some who are allergic to drugs like penicillin. We all know that whenever we give penicillin, we are very, very cautious about anaphylactic shock. I remember my teacher once during the round when I was a resident, a child had swelling of the lips with angioedema, and the child was choking. He was fighting for the breath, and I had given only antihistamines. And at that time, I had received a great firing from my teacher. He said, these are the children who need adrenaline. So my dear friends, remember, whenever a child has angioedema, the problem is deeper. It's not in the epidermis. Okay. And that's why you have to be very careful and keep adrenaline ready whenever you go for outing, whenever you go on a seashore, whenever you are going to some new place, because we can't predict as to which is the product to which the family member will be allergic to. So it's very important that you know lot many things about urticaria. We will discuss about it in the course of our presentations, and with that we will now proceed to the information related to the new molecule, that is Bilastine. And I will request Dr. Nishchal Bhatt to present on this new molecule Bilastine, and following that we will have approach to some cases from Dr. Chetan. Thank you.
Thank you so much, Dr. Pramod, for just beginning a very important topic. And as we all know, since almost 1 year since the pandemic started, the infectious rate in the children has gone down drastically. And the OPD has become almost 1/3 of what we used to see in last maybe season or February. The commonest reason is children are not going to school, so there is no cross infection. They are eating home, so they are absolutely good with their GI tract, as well as there has been a very proper use of cleanliness and sanitization of their hands also. And the family member also have become very particular about cleaning things, including the food that we eat. So these are the common reason why the infection has gone down. But as we have seen the trend in the developed countries, as infection goes down, the allergy rises. So India is in the midst of that situation in which next 2 to 5 years, we will see an upsurge of allergic conditions starting from rhinitis, sinusitis, rhinoconjunctivitis to asthma and all other morbidities related to that. So being a practicing pediatrician, we all must be updated with the current trends of what is allergic and what are different molecules which are available. So let us begin with the topic, that is the revolutionized antihistamine initiative for science in excellence. So if we see the history of antihistamines, and we will be really surprised that it is more than 70 years old. And if we see the trend of the antihistamines, how it has been developed. So around 1950s, the CPM came, and the estimazole came around 1980-85. Till that, it was the first generation antihistamines. From 1988, the cetirizine and loratadine came, and the levocetirizine came in 2002, and the bilastine came in 2010. So almost from 1988, we have the second generation histamines which are available with us. So this is the history of antihistamines. If we see the comparison of the antihistamines, then we'll realize why the need of second generation came when already first generation was available. Because first generation was non-selective and has anticholinergic effects, and the half-life of the molecule was less, so it was required to be given for 3 to 4 doses daily. And we all know the compliance of the parents and the child. If it is more than twice in a day, it becomes very difficult for them to give. So the second generation have selective H1 receptor agonist, usually administered once or twice in a day, so very compliant in nature. The first generation used to cross the blood-brain barrier, and that is why it causes the side effect of sedation. If not properly sedated, then hyperactivity and insomnia in children. Whereas the second generation does not cause blood-brain barrier, and that is why mildly sedated or may not be sedated if we go next generation. The first generation had effect on QT prolongation. There is more drug-to-drug interaction and was metabolized in the liver. So it was not possible to give during any disease which is pertaining to the liver or the kidney. Whereas the second generation does not cause QT prolongation. There is no drug-to-drug interaction, and it is now easily available. So if we go for the characteristics of the second generation cephalosporins, then it has binding affinity for specific H1 receptors. They have faster action and longer duration of action. It reduces the ocular system in rhinoconjunctivitis very faster and very less and less sedation, which has been seen. So what is a requirement of ideal antihistamine? And this is very excellent table which has been given, that pharmacological properties should be potent and selective activity against H1 receptors, no clinically relevant pharmacokinetic interactions with food, medication, or intestinal proteins. There should not be interaction with cytochrome P40 and can be given along with other diseases also. The efficacy should be there in both intermittent and persistent allergic rhinitis. It should help in nasal as well as ocular symptoms, and should have been properly studied in children and elderly patients, and it should be safe. If we see the side effects, there should not be any sedative side effects or cognitive or psychomotor impairments, no anticholinergic activity. QT interval should not be affected, so safe for the cardiac issues. Can be used pregnancy and breastfeeding also. And as I have already stated, the study should have been conducted in young children and elderly patients. The last and important thing about pharmacodynamics is the onset of action should be very fast. And it should be long duration, so that once or twice in 24 hours should suffice for its effect. And we all know the first line and the initial second generation antihistamines has effect on tachyphylaxis. So it should not develop the tachyphylaxis as the time passes. So we have a new molecule, Velastine, and if we see, it is a modern non-sedative second generation H1 antihistamine. And the most important thing is that it has the highest number of desired features that a modern antihistamine should be there as per the international guidelines. If we see the structure of Bilastine, why it is non-sedative specific H1 receptor antagonist, because it has hydrophilic carboxylic substituent chemical structure. And this is the structure which contributes to the low penetration into central nervous system. And that is why it is almost non-sedative antihistamines, and it works fantastically well in cases of allergic rhinitis. If we see the approval of Velastine, the DCGI has approved it for the use of allergic conjunctivitis, which may be seasonal and perennial, as well as in the cases of urticaria. If we see the European academic and clinical research, Velastine can be used as a second generation antihistamine and one of the first line of treatment in urticaria, as in the guideline of management of urticaria by ECI, and can be used very well. And Velastine has been approved in the use of European Union in 2010 and is currently being introduced into clinical practice in 28 countries of European Union in the symptomatic treatment for allergic rhinoconjunctivitis, which may be perennial or in our patient, it was seasonal. If we see the pharmacodynamics of the Velastine, it is H1 receptor antagonist and has mild anti-inflammatory effect also. Very selective H1 receptor. It has 3-fold greater affinity than that of cetirizine and 5-fold greater affinity than that of fexofenadine. It has also got a very long duration of action. If we see, it is 73 plus or minus 5 minutes is the half time of the of Velastine, and it has got prolonged H1 receptor antagonism in vitro. Pharmacokinetics is also very critical. If we see the duration of the induction of the action is 1.1 to 1.5 hours. So it is coming very fast. The half-life is 14 and a half hours. So it is almost 24 hours it stays in the body. As it does not interfere with cytochrome P 450 metabolism, there is less and less metabolism in the liver, and 2/3 of it is excreted in the stool, so can be given also safely in cases of renal disorders. The dosage which has been established in children is 10 milligram once daily if the child is more than 6 years to 11 years. The child's body weight should be at least 20 kg. It is 10 milligram OD and it is available as 2.5 milligram per ml. So it is 4 ml of oral solution OD can be given very well. So as we know, it has been licensed and a regulator authority has given it as to use for allergic rhinoconjunctivitis, which is seasonal and perennial, as well as in cases of urticaria. And it is indicated in adults and children above 6 years very well. And it has got very less tradition. If we see this 2019 paper, then we can see that it has very less occupancy on the H1 receptor of the brain, almost zero. So it is non-brain penetrating antihistamine, and that is why it is non-sedative, can be very well used as an OD dose in school-going children. If we see this paper of 2016, which was published in Pediatric Allergy and Immunology about the safety and tolerability of the Velastine 10 milligram for 12 weeks in children with allergic rhinitis, if we can see that sleeping related breathing disorders, daytime sleepiness, snoring and inattention, what they did was, it was a phase 3 multi-center double-blind study for the children between 2 to 11 years, and the indication was allergic rhinoconjunctivitis. They give Velastine 10 milligram to 260 children and a placebo to 249 for 12 weeks. And this was the result, that it was almost equal to the placebo. So there was no sleeping related breathing disorder, daytime sleepiness, snoring and inattention in these children, even if they were given either placebo or the Velastine molecule. So it was as equal to cetirizine, levocetirizine, loratadine, and it was approved for use in pediatric patient for which long-term safety data is also available. So if we compare it with other second generation antihistamines, and it was done in Vienna, Velastine had rapid onset of action within 1 hour, long duration of action of more than 26 hours. Cetirizine is similar to Velastine, whereas fexofenadine was similar on day 1, but a little tachyphylaxis happened, was less effective on day 2. There was lesser duration of action. So Velastine is like cetirizine and fexofenadine was safe and well tolerated in this study also. So if I complete my talk by take home points, Velastine is a potent, highly selective H1 antihistamine with anti-allergic and anti-inflammatory properties in vitro. It has rapid onset of action, maybe within 1 hour, with longer duration of action and has less sedation. And it meets the current European Academy of Allergy and Clinical Immunology guidelines and allergic rhinitis and its impact area criteria for medication used in the treatment of allergic rhinitis. So as I begin my talk with the pandemic, it is our response to any situation or circumstances which creates the outcome of our events happening around us. So life is like a combination lock. Our job is to find the right numbers in the right order so we can have anything that we want. And if we do all things that we are capable of doing, we would literally astound ourselves. So allergy is one area in which we all pediatricians should excel so that we can treat a day-to-day patients which are coming to us. As the infections are going down, the allergies are going to go up. So thank you so much for giving time and patient hearing. Hand over the stage to Dr. Pramod Jog to continue.
Thank you, Nishchal, for giving all this information. And I can, understand that this particular molecule is to be given once in a day. So it will also increase the adherence to treatment because the compliance will increase. Moreover, it controls the nasal symptoms as well as the ocular symptoms. So that's another great thing. And it is also a non-sedating molecule. Imagine having OPD of 100 and the 50 representatives sitting in the waiting room and Dr. Zog dosing because of some sedating antihistamine, then it will create a problem. So non-sedating antihistamine is extremely important. There are antihistaminics in the market, but they do produce a bit of sedation. So I have seen some pharma companies, they are promoting the products as relatively non-sedating. Okay, but this is absolutely non-sedating, and the experience with quite a few of our colleagues is very good. And I also like your last sentence from Brian Tracy. And now I would request Chetan to unlock the lock with proper numbers, because I expect that he gives the plan of management in a stepwise fashion. Okay, so you can start your presentation, Chetan. Thank you. Over to you.
At the outset, I would like to thank Dr. Pramod Jog for giving this opportunity to share the knowledge about the allergic rhinitis. I know because the practicing pediatricians are usually trying to run away from this situation, feeling that is not very common in our practice. But I think if we listen to Dr. Pramod Jog, and then that these kind of things are not uncommon. Just you have to keep our eyes and eyes open and our brain working. Then I think we can get the diagnosis. So what I'm going to talk in next 25 minutes or so, that how this knowledge, what is been catered by Dr. Zog sir about the allergic rhinitis, and what the knowledge has been shared by, or information shared by Dr. Nishchal regarding the antihistaminics and newer molecule Velastine, how we can really use in our routine practice. How can you diagnose a patient, and how you go, how should you have your approach to that particular patient of allergic rhinitis. So friends, so I'm going to talk about allergic rhinitis management part. So let us go with a case discussion. Here I have a case, 10 years old Rima. She was presented with a recurrent episodes of cold, running nose, sneezing episode, and each episode was to last for almost 2 to 3 weeks, and coming again for after 10 to 15 days since last 6 months. This was going on. And surprisingly, this was going on during the lockdown period. So it was associated with watering of eyes, even eyes were getting red and itching, and associated with the throat itching. So typically this sneezing used to start early in the morning, and it was more intense during that particular period. And she was feeling better when she was given some medicine, and then she was again getting this sort of episodes. So what could be the probable diagnosis? I think what the information has been given and topic has been decided to be discussed, there's allergic rhinitis, we can directly jump to the allergic rhinitis. But I think before that, we should be knowing what is the definition. As Dr. Jog sir said, it is a symptomatic disorder of the nose, which is induced by a IgE mediated inflammation after allergen exposure to nasal mucous membrane. So there are two things that are important. It should be related to nasal mucous membrane, should be following allergen exposure, and there should be IgE mediated inflammation. Now, how can you diagnose? As 4 cardinal features, Dr. Jog sir said: nasal blockage, rhinorrhea, sneezing, and itchy. Out of these 4, if 2 you have, and that also more than 1 hour every day for more than 4 weeks, I think that will give you a clue that it can be allergic rhinitis. There can be other features as discussed by Dr. Jog sir. Now, so this particular case of RHIMA may be a candidate for allergic rhinitis. Now here, for allergic rhinitis, I must say that we have to give importance to the age, because as Dr. Jog sir said, that there is an initially sensitization. The person or child comes across to the allergen, it gives a sensitization. And then when the allergen has been exposed second time, the person has been exposed by that particular allergen again, then there will be symptoms. So younger than 2 years, they are less likely to get the symptoms of allergic rhinitis. It is not that totally uncommon. It is not possible. It is possible, but less likely. So if you have a patient who is young child, less than 2 years, have persistent nasal symptoms, then we should first rule out other disorders. And then we should think of allergic rhinitis. But once after 2 years of age, the prevalence of allergic rhinitis steadily increases. And it shows that there are bimodal peak. That is, one is during the early school age and then early adult or adolescent age group. And if you have some patient who has been directly presenting to older adults, like allergic rhinitis, I think there the diagnosis is uncommon to present directly in adulthood. So there has to be some symptoms, something in the childhood. So there is a symptoms appearance, diagnosis, and prevalence. Like you might get symptoms earlier in the infancy, you might diagnose later on, maybe in the, we can say around 6 to 7 years of age, and the prevalence will be high in the adolescent age group or in the school age group. So it has been said that if you have at least more than 3 episodes of rhinorrhea in infancy, you get more chances, almost 3 to 4 times more chance of getting allergic rhinitis at age of 7. So that is the importance of early onset of symptoms or sensitization. Now this patient, Rima, does she have allergic rhinitis, or it is having simple common cold coming again, or a sinusitis? These are the common differentials. And as it has been elaborated by Dr. Jog sir, there are certain typical physical findings of allergic rhinitis. As it has been shown that this is a Denny-Morgan lines, just they are shiny appearance and folds. Then you have allergic shiners because of, they are typically saying, sir, it is a dark circles. It is shiners, allergic shiners. You have allergic solute, what Dr. Jog sir said, nasal solute. There is a transverse crease because frequent rubbing the nose. And lastly, you have allergic faces, open mouth and mouth breathing, and this particular chin has been recessed or the lower jaw is behind. This particular typical findings of allergic rhinitis, you might find in an allergic rhinitis patient who is running since a few years. Now, what you find in ENT examination, most important is nasal mucosa. There, typically, you will have pale blue hue or a pallor along with turbinate edema. You will not find the congestion or redness, which has been typically found in a common cold. Here, the running nose will be there, but it will be a clear rhinorrhea rather than mucopurulent or purulent discharge. And it has to be anterior rhinorrhea, not only the posterior rhinorrhea. There will be hyperplastic lymphoid tissue giving a cobblestone appearance. So you need to take care of the nasal mucosa, that's what is the rhinorrhea type, and the throat. Simultaneously, because it has been connected throat is to the ear and tympanic membrane, there is a eustachian tube. If there is a nasal mucosa edema, there will be a tympanic membrane, they might get retracted and there can be a serious fluid collection. So you might have, in a younger population, you might have a otitis media also simultaneously. So now, most importantly, what is not allergic rhinitis? If you have unilateral symptoms, it is not allergic rhinitis. If you have only nasal obstruction, no other symptoms, then also you should be, keeping allergic rhinitis away. Posterior rhinorrhea, that too with a thick mucus, it cannot be allergic. There has to be a clear fluid. And if there is no anterior rhinorrhea, then also allergic rhinitis is less likely. Similarly, pain, recurrent epistaxis, and anosmia as a presentation, it should not be an allergic rhinitis. Now let's go back to the case and would like to go for the history and physical examination. As previously we learned that there are certain points to go for the diagnosis of allergic rhinitis, ruling out certain things, and also to look for the comorbid conditions if we are thinking a case is having a allergic rhinitis. Like you have to see sinusitis, you have otitis, you have some conjunctivitis, you have asthma. So you have to ask these kind of things in details. So in this particular case, it was not associated with fever, no cough, no purulent discharge from nose, even no discharge from ear, no history of oral breathing, or no loss of smell. She was not specifically telling anything of food allergy, or there is no seasonal variation. There was specifically been asked what any history of pads. There is no pads, no smoking in, no tapestry, even carpets were not there. Incense sticks they are now using. These are all the triggers we all know. Now, there was some positive history, like there was a history of recurrent cough and cold during preschool years. As mother typically said, we used to go to doctor frequently. They used to give some cough cold syrup frequently. Then there was a history of atopic dermatitis. How she told she was given some cream to be applied on the face and as well as on the chin or the tibia, around on the legs. So that was atopic dermatitis. There was the history. And mother is also suffering from asthma, but she's not taking regular medicine. So we got something positive. Now, in examination, we just tried to find out whether in the signs of allergy, like what I discussed, allergy shiner, it was not there. No mouth breathing. Yes, she was doing frequent throat clearing and sniffling because of the running nose. So like that. And there was hypernasality of the voice. These three things were positive, but there was no other respiratory sound. We tried to see for the wheeze. There was no wheeze. On nose examination, typically we found that it was pale with clearly discharge from nose and there was no sinus tenderness. Now, so can it be common cold? No, because see, you know that it is usually it lasts for, as Dr. Jokes has showed, less than 7 days, 7-8 days. It should not last more than that. It is usually associated with constitutional symptoms and fever. It is not there in this case. And usually there will be family members will be affected. It was not there in history. And usually you get a treatment and you get response to that anti-cold medicine. Here it was not responding. And nasal mucosa, typically it was not red or congested, but it was pale. So that was not common cold. Similarly, allergic sinusitis, yes, it is possible. As Dr. Jokes has said, it can be a rhinosinusitis because it's a one airway. But there will be more of nasal blockage and discharge, facial pain, headache, post-nasal drip, or bad breath. But this was not found in this particular case. So I think reasonably we can put a diagnosis of allergic rhinitis. So when you have a patient of allergic rhinitis, what will be your approach? This is what we have done. Just we will try to sum it up. Patient who presents with either nasal congestion, running nose, itchy nose, and sneezing, 2 or 3 out of these 4 or all 4, then you have to go for physical and history in physical examination just to look at the chronic condition and comorbidity. So that will help you to diagnose a clinical diagnosis of allergic rhinitis. And then you decide whether it requires a treatment or not, because it is going to be disturbing the child, frequently coming again and again. So you have to decide. Now, do we need to go for any investigation at this point of time? We know that it is a clinical diagnosis. You may need to establish IgE mediation by the test, but it is not compulsory. When you have a clinical diagnosis, you can go ahead. So whenever you go for some routine laboratory investigations, they will be all normal. And these, there is a tradition of going for blood eosinophil counts. That will be high and that will be showing allergic tendency, or somebody will go for total serum immunoglobulin, IgE level. So that is also not going to help in a diagnosis because it is elevated in only 30 to 40% of cases. And there are other reasons also for the getting it elevated. So I think that they are not a diagnostic for allergic rhinitis. So now, once you have put a clinical diagnosis, how will you manage the patient? There are 5 important pillars of the management. Out of that, green, which have been shown, avoidance of allergen and irritants, parental education and monitoring. These 3 are common to all and they are important. Yes, you are going to go for pharmacotherapy as well as allergen immunotherapy when it is required, but rest of the 3, it continues. So we have to put stress on it because we know that it has been caused by the allergens or irritant will increase its occurrence, and parental education as well as monitoring is important. So first, when you decide to treat these patients of allergic rhinitis, we have to decide which phenotype patient is in. Now, there are different phenotypic classification. We will just take it into account and will decide how to manage this patient. So as this has been shown by Dr. Jokes sir, whether it is having intermittent symptoms or persistent symptoms. That means a rule of 4, less than 4 days a week or less than 4 weeks per episode, or more than 4 days a week and more than 4 weeks of episode. If it is that is persistent. Mild or moderate to severe. So if it is not having a disturbance to sleep, work, school, daily activities, I think that is a milder variety. And moderate to severe, that means it is disturbing the daily activity, schooling, work and sleep, then it is a moderate to severe. Then comes the other phenotypes, like what are the predominant symptoms? As it has been shown that it can be a sneezers or runners, or it can be blockers. So if you have a child who is sneezing or running, then you might use certain group of the pharmacotherapy like antihistaminics. While if they are blockers, you would like to use a decongestant. So that's why it is important. Disease control. Now, a latest classification and management in adults on adolescent is based on visual analog scale. That is, they will be classifying your symptoms control. And according to that, they will go for stepping up the therapy and ultimately reaching to allergen immunotherapy. Now, so whether it is controlled or uncontrolled, and temporal pattern, whether it has been particular for some season or it is a perennial, that means all the year throughout. There can be a perennial with seasonal exacerbation, or it can be episodic. There is no routine, it is not occurring, but there are certain triggers which causes the episodes of allergic rhinitis. And lastly, it can be clinical, like a systemic or local or mixed. Now, what is difference between local and systemic? See, whenever you have allergic rhinitis, you might establish that it is having a IgE mediated. So you know that it is because of either you can do it with the skin testing, or you can go for the specific IgE antibody testing. Now, if you have the local allergic rhinitis, in this particular group of the patient, you have a negative skin prick test, and there is the absence of specific IgE antibody in the peripheral blood. So yes, it is same like seasonal, perennial, intermittent, persistent, same. But the diagnosis is based on a clinical history as well as a positive response to nasal allergen provocation test and or the detection of nasal IgE. So here, why it is important? Because here you need to go for a subcutaneous allergen immunotherapy rather than other, because this is going to be more effective. So that is one word about local allergic rhinitis, because it is not been diagnosed properly. It is a misdiagnosed or underdiagnosed. So now looking at the history, physical examination, what is our case phenotype? Rima. She is having a mild intermittent allergic rhinoconjunctivitis, because there is the element of the eye involvement also, and there is a rhinitis. So allergic rhinoconjunctivitis without any comorbid condition. It falls into the sneezers because there is no blockage. She's not disturbed with the nose, sleep, but there is having running nose, and she's having uncontrolled temporal pattern, not yet been established because it is just like 6 to 8 months. So this is our case phenotype. Now, as we said, there are 3 main pillars: allergen and irritant avoidance is very important. And commonly, if you just close the eyes, and these 6 things are most common allergens: dust mite, cockroaches, fungi. These all are indoor. Pollens outdoor, pets definitely indoor, and food. These 6 allergens are common to cause the allergic phenomena. There are irritants that will, stimulate this particular all cascade, and like a tobacco smoke or a mosquito repellent, or you have automobile exhaust. Typically, what happens? The scooter or two-wheeler person starts, and there is the fume which is coming out, the fog, and that kid is just standing behind it. Then there are some viruses and cold air. So these all are the irritants. You have to tell them to avoid as far as possible everything to decrease the episodes. Parent education or patient education. Now here we usually have a grown-up kids. So you have to take care of patient as well as parent education. You have to tell them that this particular, suppose this Rima has come for the first time or initial period of time, the likelihood of disease progression, what is the nature of disease, and you might need a long-term treatment. And we have to re-establish that the treatment modalities are very safe. You might have to go for intranasal steroids, and they have to, make the clear in their mind that it is fear of steroids should not be there. Then compliance, adherence, and effective follow-up is very important. So you have to tell them right on first consultation. These all are important. Then you have to explain about the avoidance of triggers and immunotherapy, which is available, and you have to educate the technique about the devices, particularly if you are going for the inhaled corticosteroid, inhaled medications. Now, monitoring is also important because you have to treat according to control, last added drug, suppose you are going for 2 or 3 drugs and you are stepping up, then last added drug to be withdrawn, you have to monitor the side effects of all the drugs like antihistaminics or steroids, everything. Follow-up visit is important. You have to call them 15 days after that, and you have to watch for the compliance, symptomatology, quality of life, whether it is improved or not. And lastly, every time, just like asthma, when you are prescribing the spacers and everything, you have to see the technique of inhaled corticosteroid, intranasal sprays, inhalers. So that is very important. Now, coming back to our case, she was taking a tablet, which was a combination of, it is very, typical brand, which has been taken off label, or rather over the counter available, diaminic DCA. She was taking, that is a combination of CPM, chlorpheniramine, that is antihistaminic, decongestant, caffeine, and PCM. And she didn't get better. So somebody advised that you take something like Levocet D or something like that. That's also very common. Zincet D they are taking. That is a cetirizine with the phenylephrine combination. But still, she was not getting better. Simultaneously, she was getting a drowsiness during her online classes, because nowadays she was not going to school, but there was online classes. She was dozing. So that was the problem. So let us talk about pharmacotherapy. Yes, we have taken 3 important pillars of the management. Now the pharmacotherapy. What all are the available options? There are many options, but major 4 groups are oral or intranasal antihistaminics, as discussed with Dr. Initial Bhatt, first generation and second generation H1 blockers, oral or intranasal decongestant, intranasal steroids, and leukotriene modifiers. Now let us try to understand one by one. If you use these particular 3 things, intranasal corticosteroid, oral antihistaminic, and decongestant, you look at this, which these 4 or 5 things are there, like congestion, rhinorrhea, itching, and sneezing. This intranasal steroid are affecting or giving effect on all these 3 symptoms. While oral antihistaminics, they are working more on rhinorrhea and itching and sneezing. While if you use oral decongestant, they'll be having effect on congestion. So you have blockers, there you use oral decongestant, or you have a nasal blockade. If you're running, so this particular information is useful for us to decide which particular pharmacotherapy to be taken into consideration. Yes, definitely you have to look at the duration of the effect. So that will give you how frequently you need to repeat the dose in a day, twice a day, 3 times a day, or once a day. So this is important. Now, oral antihistaminics we discussed. Yes, they are H1 antihistaminics, H1 blocker. They are 2 generation, first generation. But important is to realize that diphenhydramine, chlorpheniramine, and hydroxyzine, these are the first generation antihistaminics, and they are part of the routine cough cold medicine whenever it has been given. So it is having a limited role because they are having a numerous adverse effect, as it been discussed by the Dr. Nishal. Now, second generation antihistaminic, now that is a need of an hour. That gives, a group of the drugs like cetirizine, fexofenadine, loratadine, Velastine, which is new entrant. It is having a minimal sedating, or rather no sedation, and it is preferable over the first generation because efficacy is similar, but there are fewer CNS side effects. And most importantly, the onset of action is within 1 hour. And usually it is to be given once a day. And there are other advantages like Velastine. It is an antihistaminic which are been giving more of anti-inflammatory effect. So that is advantageous, as well as it is a long half-life, so single dose is sufficient. Also, there is a CNS penetration is very almost nil for Velastine. So these are the points to be kept in mind. Yes, cetirizine or fexofenadine, all other having a less CNS penetration, but Velastine is having a no CNS penetration. Now, antihistaminic nasal spray. This is like we have 2 options, azalastine and olapatadine. Here we have different strength. Only thing is this has to be used more than 6 years of age. And you have a combination of azalastine, fluticasone combination, nasal spray is available. But most important problem with azalastine is it is having a bad taste. So that's why it is not been tolerated. Now, second group, oral decongestant. Here also, if we try to remember the name phenylephrine, pseudoephedrine, usually we get a combination of antihistaminics and decongestants. So this kind of formulations, or you have this with expectorant and suppression. So because of their potential side effect, because these are alpha adrenergic agonists and they are sympathomimetics, so they'll decrease the vascular congestion, but they'll be having potential side effect like hypertension and cardiac rhythm abnormalities. So it has not been used that frequently unless it has been specifically indicated. You can use nasal decongestant. That is also important, because that when there is a nasal blockade, I think these are the rescue medicine which we can use. But most important thing is there are two, oxymetazoline and xylometazoline. There are different strengths available. So for oxymetazoline, we have 0.01%, 0.025 and 0.05%. So depending upon age, they have been recommended. But only thing is, yes, they are useful because it is rapid onset of action and congestion is predominant, it will be helpful. But because they are decongestant and they are prolonged use, will reduce the ciliary activity and ultimately rebound congestion and rhinitis medicamentosa. So that's why whenever we usually use a saline nasal drop. Rather, when you want to use decongestant as a rescue medicine, just take care that they should be informed that it should not be used for a long period of time. Then one word about Montelukast. It is very much discussed and very favorite drug of many of our friends. But most importantly, Montelukast, yes, it is a leukotriene receptor modifier. So it is not having any role as a monotherapy in allergic rhinitis without asthma. It is only useful when it is having coexistent asthma. Second thing is, there are combination with antihistaminics and Montelukast, and there is no added advantage. So that these combinations are not approved. And Montelukast is effective in certain situations like obstructive sleep apnea associated with allergic rhinitis. And most important, why we are not using, because now there is a box where warning on Montelukast, because there are chances of suicidal tendencies and hyperreactivity. And particularly these drugs, when they are using in adolescent age group or a school age group, this is very important side effect. So that's why it is better to avoid this particular drug. Now let's go back to our case. She was on oral antihistaminic and decongestant combination off and on, but the frequency of the episodes were increasing, and now her night sleep was also disturbed, daily routine was also getting disturbed. So I think now they are shifting to the moderate to severe category. So she was advised nasal steroid spray, but the mother wanted that, you are telling doctor allergic rhinitis, allergic. So what the allergy is? So let us go for the allergy testing, and that's correct also. And when you talk about intranasal corticosteroids, I think it is the single most effective maintenance therapy in allergic rhinitis, and because it causes a few side effects as recommended ACs. So it is very safe. There are two particular generations, this beclomethasone and budesonide. These are a first generation. And second generation, which is more commonly used, fluticasone, mometasone, or fluticasone propionate, as well as furoate and cyclosinide. Now, what is the difference? There is a bioavailability. Look at this, 10 to 50% bioavailability in first generation. So that means this particular, they are getting absorbed, so side effect. But there, the bioavailability is very less, so they are not getting much absorbed, so less side effect. So if you have a child whom you have already started with pharmacotherapy, and there is no response, then at that particular point of time, we might go for the specific IgE allergy testing. And we have two options. One is in vivo and in vitro. So what is in vivo? That is a skin prick testing, and in vitro is our enzyme assay or immunoassay. Now, there are other options. People are thinking of total IgE, which I already told in the beginning, that the sensitivity is very less. Specificity also less. There are other conditions where, like atopic dermatitis, parasites, infestation, or a viral infection, or hyper IgE syndrome, there it will be increased or elevated, even then there is no allergy. So the performance is not good enough for screening test. So we should not use total IgE, rather specific IgE should be considered. Now in vivo, you can go for skin test, and in vitro, you have a different test of immunoassay. And what is latest available is a immunocap. So this is the latest in addition, and that is automated enzymatic IgE immunoassay. Now skin test, yes, it is the gold standard, as we can say, because it will give a clear-cut result that with this particular allergen, the child is sensitized or rather allergic to this particular agent. And here you give a negative and positive control, and then you give in between the allergen which has been epicutaneously been injected in the skin. And then, because we know that allergic response is through histamines, so histamine will be released because person is already been sensitized. And if you give the allergen, that particular allergen will go inside the skin, and the mast cell will be sensitized. There will be decannulation, histamine will be released, and it will give wheal and flare reaction. So what is wheal and flare? Is elevated followed by redness surrounding it. And if it is more than 3 mm, then it is positive. So this is skin test. It is highly sensitive. It gives immediate response. It is cheaper, but unfortunately it requires expertise, subjective, and suppose the child has received antihistaminic drugs, I think there will be a false negative. Similarly, it is not comprehensive and patient compliance is the problem. As in my case, the patient was not ready for skin testing. So second option is Phardiatop, which is immunoassay, which is available. Here it is a blood test that will give you a specific IgE antibody against a specific allergen. But there is something like a group of the allergens they will be giving together and they will look at the specific IgE response. If it is positive, then you can go for specific allergen testing. So that is the way we can go ahead. So what is the difference? As I said, the immunoassay is not been influenced. Suppose if patient is taken antihistaminic, you can go for it. Suppose patient is having atopic dermatitis or eczema, their skin test cannot be done, but this immunoassay can be done. And it has been standardized, so it is not having an observer the fallacy, but yes, it is expensive. Most important thing for this specific IgE estimation is you have to identify or scrutinize the history and say these are the allergens which are likely in this particular patient. Their specific IgE should be done rather than a full set of it. So that is the way we go for that. In our case in Rima, what happened? We went for that rhinitis, that there are certain allergens, we went for it. And what we found? Cat allergen positive and some pollens positive. Look at this. So we were repeatedly asking about PAD, but unfortunately, they were not giving history because the cat in their house was coming and going. It was not PAD. So the younger brother, he liked the cat. So the cat was coming every 2-3 days, and for the milk they were giving, and she was moving in her house and then going away. So they thought it is not a pet of their own self. So that was the cat allergen. Most importantly, it is a very strong allergen. Cat allergen is even worse than the dog allergen. So if you have pet of dog, I think cat is worse than that. And usually, if you are exposed, the child is exposed to cat allergen, that will stay for almost 6 months, even after you remove the cat from the house. So that is important. And this particular case, then we started with nasal steroids. And along with that, here, because she was already on antihistaminics, even second generation, but she was having an issue of the concentration ability. And because we had the Velastine, which is a wonderful molecule, is having a specific Ig, rather H1 receptor effect, and single dose sufficient. So we started with intranasal steroid as well as oral antihistaminic, that is Velastine, and she responded very well. Yes, we needed to continue for almost 3 months, and now still she is on that. So this is the role of the antihistaminic. So this was about the case. Now, in general, when we have a case, what is the treatment flowchart? This is important. You have to define which is a phenotype typing, where you have either you have a mild to moderate or intermittent and persistent. Suppose you have intermittent and mild, you will go for a either oral H1 blocker or intranasal H1 blocker and or decongestant. Suppose there is an obstruction, you will use decongestant with that, or LTRA, which is a less preferred option. Suppose it is having a intermittent and moderate severe or persistent and mild, then you can go for again oral H1 antihistaminic, intranasal antihistaminic, and or decongestant and intranasal corticosteroid. When you have a persistent symptoms, I think intranasal corticosteroid comes into action. Suppose you have persistent and moderate severe, we have to go for intranasal corticosteroid as well as H1 blocker. So as we did in our case, because the patient was having a moderate to severe symptom, then you have to review after 2 to 4 weeks. If it is improving, yes, you can go down and you can gradually, 1 to 2 months or 3 months, you can step down. If it is not working, then again you have to review the diagnosis, review the compliance, you check for the infections, and if you have, like suppose you have given intranasal corticosteroid, you can increase the dose. If there is a rhinorrhea part which is disturbing, you can add ipratropium. And if there is a blockage, as I said before, you have to add the decongestant. Yes, allergen and irritant avoidance is very important. In our case, we use Velastine. Why? Because the child was having a allergic rhinoconjunctivitis. So when there is the element of the conjunctivitis, then I think Velastine will score over others. So there are certain clinical scenarios. As I said, if there is a nasal congestion, you go for oral decongestant along with an INS. If you have intermittent sneezing, then oral antihistaminic with internal or intranasal antihistaminic. If you have milder symptoms, I think oral antihistaminic is fair enough. If you have moderate severe, as I said, intranasal steroid, intranasal antihistaminic, or a combination. Rather, combination has to be given. And sometimes we are talking about acupuncture and all that. I think the evidence is still lacking. So this is in general, how will you have approach of the allergic rhinitis? And this is another case I would like to share. A girl, she is coming again and again, is going to the practitioners with these kind of lesions on the body, around 10, 11 years old girl. And every time she used to take some medicine, so antihistaminic, and she used to get better. That's coming again and again. So here, look at this. These are typical cases of urticaria. And they tried to figure out what a particular allergy they are having. They didn't find anything. So this particular case, as we know, as Dr. Nishal said, that is going to be a first line of treatment, Velastine. So she was started on that. Most importantly, people are starting the antihistaminics for some time and then they are stopping it. Ideally, we have to continue for the long period of time. And if you don't get a response to antihistaminic, you have to increase the dose. Double, even 4 times the dose you can give it. But the issue is, if you give the dose in the 4 times, even the second generation, other than Velastine, they are going to have a side effect of CNS side effects, and there can be a the CNS side effects like they are having a sleepiness in the morning or disturbance in the daytime. So this is all about the use of Velastine in our clinical situation. Thank you so much for the patient listening. Thank you so much.
Thank you, Chetan, for elaborating this particular topic very well with the help of a case. And as I was listening to it, I thought that, our MBBS and the MD students must have a long case of allergic rhinitis, because usually they are getting all cases like rheumatic heart disease and so many others, but nobody is bothered about these common scenarios. That's very good. So we have already started receiving quite a few questions from our colleagues in Gujarat. And Dr. Nishchal, there is a question about Velastine as a molecule, as to how early you can start giving this molecule and how long can you continue in a child with allergic rhinitis. So can you just throw some light on that?
Yeah, the current DCGI recommendation is to start more than 6 years children. 6 to 11 years, we can give it at the dose of 10 milligram OD. More than 12, we can give 20 milligram OD. Actually, from 2 to 6 years, the trials are going on, and chances are there it will definitely approved at the earliest. We can give continuously for 3 to 6 months also, and the safety profile which has been studied in 2016 paper is very safe to give even for 3 to 6 months continuously for in the cases of allergic rhinitis. So earliest at present 6 years, and we can continue it for 3 to 6 months altogether if required.
Right.
I think it has, Dr. Jog, I think it has established the safety. So even if you use it before say suppose 4 years, 5 years, I think there will be off-label use, but there should not be any problem.
Okay, very good. And Dr. Chetan, you already mentioned about the traditional romance of the combination of antihistamines with montelukast, and it's not a very rational combination. However, I will also like to add that the pH of both the molecules, the antihistamines and the montelukast, is different. And in the syrup form, many times these combinations are not very stable. And that's why our listeners should, as far as possible, not use the combinations. They should use it separately. In a tablet, usually there is a biofilm between these two molecules, and that's why a tablet form sometimes is given by the physicians. However, in pediatric practice, the syrups are better avoided. And now there is another question.
Also, sir, would like to add one thing.
Yes.
Because these syrups, they are having a fixed dose combination. So we are compromising on dosage part also when you are using this particular combination. And simply, as you said, the pH. So one drug is getting absorbed in stomach and other is at duodenum. So when you give it together, I think that will not be working properly.
Yeah, the combinations are said to be unstable.
Yes.
Yeah. One more question, Dr. Nishchal, about Velastine is what is the way to improve the compliance to this medication? Because the question is also related to whether it should be taken on empty stomach And if so, then what should be the interval between the food and the intake of the medication? So what is your opinion?
See, as the half-life of the molecule is 26 hours, it is only to be taken once in a day. And as it is non-sedative, can be taken in the morning hours or at the night also. And it can be given just before the food. And there should not be any disturbance of food or after food, because the molecules are very inert, and it can definitely given just before the food also.
Yeah, the usual recommendation is probably that it should be given on empty stomach with some gap between the intake and the meals. That's very good. And also, some listener wants to know as to what are the guidelines. I think initially already clarified that there are guidelines from the European Society as well as from the area guidelines. Dr. Chetan has already mentioned about allergen avoidance. I would like you to share your experience, and particularly the way in which you inform the parents about avoidance of particular allergens. So I'm sure in your practice you must have witnessed parents who keep mentioning that the child is allergic to this and allergic to that. So do you have any additional experiences to share in addition to what Dr. Chetan has shared in relation to the avoidance of allergens?
Shall I? You asking me, sir, or Nishal?
Yeah, I was asking Nishchal because you have elaborated quite in details. So if he has anything to offer, then we will like to know.
Yes, nothing to add, but anything under the sun can cause allergy, and we have to be very careful about each particular child. And as Dr. Chetan has already history, because the cat was not pet cat, but it was visiting the child and was to, and we definitely get very recurrent patients who come up with Ratre Sutta. At the time of night, child was fine, and when he wake up, he has lots of allergic urticaria around all over his body. So there must be something in his bedroom. Many a times the AC is not serviced properly. A fungus is getting around, a damp part around the child where child is sleeping. These are the very common areas where dust mites and all other things are getting together, and these can cause various allergens. Nowadays, in the month of February, March, because of lots of pollens are also causing lots of allergy. So these are the months in which definitely we'll see the increasing of allergic rhinitis, rhinoconjunctivitis, as well as the exacerbation of the bronchial asthma in children. So these are the months where we have to be very careful about and continuously talk to the parents. So these are the few things which I just wanted to add. Dr. Chetan, if you want to add anything in that.
I think I had, few, cases we remember for lifetime. So one is the cockroach allergy. Nobody is ready to believe that their kitchen are having cockroaches, and cockroach having a very strong allergen. Second thing, when you are using a broom, a new broom they get that they pocha karne ke liye. So that ultimately having so much of that small little things into it. So we have to tell them that अभी नया झाड़ू लाओ ना, पहले बार बराबर ठोक के फिर अंदर ले जाना, या अगर घर में बच्चा है तो अवॉइड करो, या फिर ड्राई मॉपिंग मत करो, वेट मॉपिंग करो. एक ये चीज है. Second thing is because the humidity is a factor for certain allergens, so you have to keep the humidity low, right? So in that case, people are thinking that AC is going to harm, but AC is better because that will reduce the humidity. So these are the points. And there was one patient where they were staying in a pole in our area. We have houses which have been so much clubbed together, and there was a not airy room and everywhere. So there is a kitchen, everything nearby, and there is some because of the leakage of the water, there is a fungus typically. So if you have that sort of thing, popdi batti hai bolte hai na, do bathroom ke side mein, child used to go there, and that caused the allergen. So these are the things which are very important. अगर नया घर में कलर करवाया है, आजू-बाजू में कहीं construction work चलता है, these are the typical stimuli like irritants which are causing the problems.
Yeah, that's very good. In fact, I also advise parents to keep their footwear outside before they enter into the house. And in addition to the information about the cockroaches, remember, never crush the cockroaches. If you crush the cockroach, the allergens from the cockroach, they fly off in the air, and they are very potent allergens. And all the pets, including the husband, should be remembered, but he should not be out of the bedroom. Only the dogs and the cats should be out of the bedroom. And remember one more thing, now the schools may reopen sometime. Children usually are carried by the parents on the front side of the scooter, and the blast from the trucks in front can many times, give many pollutants. Also in the house, there are these agarbattis and mosquito coils. Many children are allergic to that, and one has to be very careful. So there are many things which we need to tell our parents. In fact, we have some leaflet, which gives all this information, because the cases of allergic rhinitis always need a lot of information, right? So I think with that we will come to the end of this particular discussion. I will just like to give some salient features. The molecule Velastine, though it's like a new film release, we have to review this periodically, at least for the next few years. And I'm sure this particular molecule holds a great promise. It has a fast onset of action within half an hour. It continues to work for almost 26 hours. It is very safe. It doesn't produce any sedation, and it doesn't have any impact on the liver or the kidney function. And many guidelines have recommended the use of this particular molecule. Recently on the Valentine's Day, one of my friends gave a red rose, to his Valentine. But instead of smiling, she started sneezing because she was allergic to the pollens from the rose. And that's why be careful, at least on the next 14th of February. Till then, goodbye. And in case if there is any query, please feel free to put it on the chat box. We will try to answer that. So thank you, Dr. Nishchal and Dr. Chetan, for joining this discussion. And then thank you, listeners, for listening to us and asking the questions in large numbers. Thank you very much. Thank you.
Thank you so much. Thank you, Doctor.
Thank you, Dr. Ishal.
Thank you so much, Dr. Chetan. Bye.
Thank you, sir.